Welcome you all to the session 5 of the Cervilon Masterclass series, Practical Physiotherapy Rehabilitations in Spine Disorders and Clinical Application for Ayurvedic Physicians. Today we have with us an accomplished physiotherapist whose expertise bridges the clinical practice, rehabilitations and academic excellence. Our faculty, Ms. Sreelakshmi K, hold a Master in Physiotherapy in Cardiopulmonary Science and Critical Care from Yanobaya Physiotherapy College, Bangalore, and a Bachelor of Physiotherapy from Lakshmi Memorial College of Physiotherapy under the Rajiv Gandhi University of Health Science, Karnataka. I will like to now welcome Mrs. Sreelakshmi K to take the class. Welcome.
So, good morning all. Today we'll be having a session on practical physiotherapy rehabilitation in spine disorders. So, we'll be focusing more on the clinical application. So, it will be a rather more insightful session for you guys to have an approach on the exercise sessions, how you can approach and how you can implement a purely effective exercise rehab protocol. Right. So we'll be purely focusing on evidence-based assessment and treatment plans. So the objectives for today will be we'll have a short intro for the pathoanatomy and the clinical classification, and apply evidence-based assessment strategies and how to select and implement appropriate interventions. And we will be looking on to certain RCTs and as well as systemic reviews to build a better rehab approach. So this include an epidemiology and impact of the spine health, or purely looking at the cervical spondylosis, and pathoanatomy, how the disease progression. Everyone must be knowing these factors, but we'll have a brush up on these elements, and the clinical classifications, the evidence-based assessment, physiotherapy interventions, and how we can purely segregate all the pain and or disability factors, and so which will include outcomes and evidence, and we'll have a clinical guidelines that as well as a questionnaire and sessions at the end. So the spine health, it always accounting with the degeneration as such as age progress. As with the other elements like the muscles and all the parameters in our body, we are prone to get degeneration, the wear and tear. So cervical spondylosis, it refers to an age-related degenerative changes which affects the cervical spine, including the structures around it. So these changes gradually reduces our mobility, and there will be stiffness around guarding will be there, right? So we are focusing more on regaining the mobility and reducing the symptoms whatever they have, and to improve at last finally to improve the quality of life and well-being of the person or the patient coming over here. So as you can see, as per the studies, it's a 90% there'll be more chance of radiological changes happening. We can see, but the thing is, like, even though as studies proceeds, that's radiological changes are happening more than like 60 years, above 60 years. But lately, around 30 years, late 30 years or 45 years, because of the lifestyle we are following or the postal changes, the degenerative changes can happening at the earliest. And the prevalence, looking into the prevalence, the neck pain disorders are happening the second most common musculoskeletal complaint. This asking being the first, it is always the back pain. So it's common is the neck pain, and the recurrence rate is 5.5% of global prevalence. And once the person accompanied with the neck pain in with the 5 years or in with the second year or the third year, the patient can again come up with the recurrence rate of neck pain. So the key epidemiological facts include the cervical spondylosis accounts for about 2 to 3% of all emergency departments. So we are encountering recurrent number of all the aches and pains, including with the back pain and neck pain or whatever it is. So the annual cost of it holds an economic burden in the society. That is, annual cost of neck pain include more than, like in the US, it exceeds more than 90 billion in direct and indirect costs. So as well as the neck pain, it grades with axial and cervical radiculopathy and as well as the myelopathy. The incidence is more in the male than the female and the for myelopathy, but rather when you're looking into the radiculopathy, there is an equal distribution. And looking into the work-related neck pain pattern, that it not just currently we are looking when we are looking into the data, it not just the work-related pattern. Even in the students and all the age groups are nowadays getting the neck pain. And accountability here, they are telling 11% of total disability adjusted life years in occupational settings as per the WHO 2021. So being a physiotherapist, what our role is to merely to reduce the pain and to identify the underlying cause. What is the causative factor to for them to have the, even though it is a degenerative issue, but there are certain functional anomalies or the ergonomic pattern that we can change to get them better, to attain a better quality of living, and classify the patient correctly, screen for serious pathology, and implement evidence-based rehabilitation strategies. So we have to triage the patient according to the pathology, whether we can treat on here or whether we have to refer to the higher centers or tertiary sectors. And according to that, we will be creating a rehabilitation protocol or strategies. So it will be like one-on-one treatment plan or one-on-one strategic plan. We can't implement all the certain exercise or all the modalities or whatever we are planning to the all the same categories of patient. It will be differ on one-on-one because the lifestyle they're following, the activities they're doing, or the work they are doing, everything will be differ on different individuals. So the pathoanatomy, as I said before, it has certain stages like we'll be initiating with the degeneration. So it can happen from your early 20s or 30s, depending on the lifestyle you're following. So for example, if you are more prone into a sitting lifestyle, so take an example of a person who are engaged into an IT field or a desk job. The person is sitting for say like 8 to 10 hours or 12 hours throughout without having any kind of mobility in between, like major mobility in between. So that will impart a certain kind of pressure over the spine. So on a long run, there will be chances there will be hydration of the pelvosis, and there will be initiation of the disc degeneration. And further, on a long run, as this load will be imparting to the other structures like this, followed with the segmental instability, so that the ligamentum flavum hypertrophy will be there, facet joint degeneration will be there, and compensatory osteophyte formation will be there. That we can be visible in your X-ray or radiological findings, whatever the patient coming in with. And on the third stage, there will be compromise of the neural structures around it. There is narrowing of the canal or adjacent thecal sac, which will compresses the nerve root and will be associated with tinkling or burning sensation or pin and pricking sensation. And at last, there will be functional impairments that can be modified into myelopathy. There will be bowel and bladder issues. So that there are certain aspects that we have to look into what are the structures involved and how we have to term the approach or the rehabilitation protocol as well. So this is a degradation of the classification of the neck pain, which include an axial neck pain, then cervical radiculopathy and cervical myelopathy. And looking into the axial neck pain, so initially the person might be starting with a dull aching or a point pain over any area of the neck. So that has a prevalence of 85%. That can be starting with, as I said, your 30s or 40s. It can be because of the way you sleep, the way you sit, or how much ever you're imparting or stressing your posture, or your without engaging any kind of physical activity, that is following any kind of sedentary lifestyle, without following any strengthening or resistance exercises. So the key features for that will be including the pain localized to cervical spine. There will be like point pain wherever there is more of the pressure, and it will be associated with a range of motion, the neck mobility. So the person coming in will be telling like that, I have pain over the neck, the like posterior aspect or over the like lateral aspect, and difficulty in moving around the neck, like looking to the side or up or down or wherever direction it is. And also it'll be complaining of muscle guarding and tenderness. Muscle guarding as such, initially will be more in the morning, as there is guarding around the structures not to move further. So there'll be guarding initially in the morning in a severe form, and it'll be getting down as you mobile, but still the person can feel a persistent amount of guarding around that particular structure and tenderness as well. The guarding initially, even though it'll account only in your neck, it might be radiating, or it might be affecting your thoracic spine as well. So that there'll be patient can be present with neck pain along with your mid thoracic pain and mobility restriction as well. So looking into the neurological deficit, there won't be any much of compression happening over there, so that there won't be any neurological deficit or tingling sensation or pin and pricking needle or radiating pain happening to the patient coming in with axial neck pain. So on a long run, if the person is not getting treated for the neck pain or the point pain or the discomfort currently the person is having, which can further move on to radiculopathy, that is cervical radiculopathy, where the dermatome or the nerve root or the nerve structures can be affected. So along the course, there will be pain, that is radiculopathy, and it can be associated with or without paresthesia depending on the grade. So the prevalence, as per the study, it says is 83 on 100K. And to rule out this, there are certain special tests, like one among the mentioned is Sperling's test. So the sensitivity they've mentioned is 30% and specificity is 93%. So the patient might be presenting with the radiological pain. The weakness will be there, and the reflex, on checking it, the reflex, it might be affected, like it might be hyporeflex, and in some certain cases it might be hyperreflex as well. In some certain cases, that is very rare cases. And the mostly coming into the cervical region, its affected root will be C5, C7 root. And in cervical myelopathy, there is degradation happening, and the prevalence is 4.1 of 100K as per the studies. And the patient coming in with hand clumsiness, there will be a dexterity problem, gait disturbance, and gripping strength. Gripping problem, and the cervical flexion, that is Lemaitre sign, will be positive as he provoke it, or as he try to bend or flex her neck. There will be irritation, or there will be a recurrence of the symptoms. And the sensitivity, as per the studies, it says 27%, as well as it can be associated with upper motor neuron signs of stiffness and hyperreflex. And according to the on scaling, we are using modified Japanese OA scoring scale is used to rule out or used to get the severity of cervical myelopathy. So coming to the subjective examination, so we are looking into certain outcome measures to rule out or to grade the symptoms as well as the disability of the patient. So which will include the history as well. As usual, we are asking for all the patient over here, the onset, whether they have any kind of trauma, how long it has been, and the aggravating and the relieving factor. So coming into the aggravating factor, many of them have aggravating factor like on moving, or might be driving, sitting for a long time, depending on their activity. And the relieving factor, easing factor, and a compensatory form or any kind of medications or lying down. And we also have to look into certain functional impact, how well their quality of life affected in terms of functional habits like driving, sitting for a long time, sleeping, whether it is happening in whether it's getting aggravated while doing any kind of lifting activities as well. And coming into the posture, apart from the validated outcome measure, we are also looking into posture. Say, for example, a person coming on with upper cross syndrome. That is, upper cross syndrome is a musculoskeletal postural issue that is usually accompanied with a person, as I said, sitting for a longer time. That is like the patient have the forward neck. There will be imbalance between structure and certain muscle groups in your body. So something has to be maintained in a normal way. There should be an equilibrium happening in certain aspect, like some sort of muscle will be acting in another way, and some sort of muscle will be supporting their action. So in upper crusade, whatever is happening is also looking into the system for a long time. There will be neck flexors, deep neck flexors will be getting very that action is getting very low. That is, they are getting weak, and that we have to protrude the neck to an extent, so that say for example the upper trapezius will be getting tight, and the middle and lower trapezius will be getting weak, and it will followed with then thoracic kyphosis. The scapular muscles will be getting weak, and your anterior compartment, that is your pec and everything, will be getting more of a shortened position. They are going into shortened position, and as well as your shoulder. Again, it can as far as if anything happens to the cervical region, the one structure, the around surrounding structure can also take up the load, and it can be impactful for the structures, so that the shoulder will also take up sort of load. It can go for degradation of the muscles, so rounded shoulder can happen in between. So all these muscular structures getting weak, and all the impact is getting into your spine as well. So we have to look into the postural. So postural component might be a triggering factor, or might be the primary component for that particular person to get this pain, aches, or disability, whatever we can term it is. And coming into the validated outcome measures, we have certain measures like neck disability index, numerical pain rating scale, and myelopathy Japanese OA scale, SF36, and PSFS FABQ scale. So neck disability index, it has been frequently used in the clinic sector or hospital sector to point out how well the pain index is causing them in their functional anomalies. So they have the index, the point is on index point is on 7.5, and it has a very good grade on pointing out the functional parameters, what are functional parameters that are affected for the person. So all the valid outcome measure, all these outcome measures can be used pre and post for a better review and progression of the patient, as well as to chart further treatment protocol. So the NPRS scale, again, it's vast and wide, using in all the aspect, in all the area nowadays itself, and it's a numerical pain rating scale to understand the pain sector of the patient, how severe the pain anomaly is for the patient. And the MJOS scale is a gold standard for myelopathy, again to grade the severity of the myelopathy cases, whether it's grade 1 or whether we have to refer to the tertiary sector, or that is like if it's grade 1, we can go for the conservative management, or other than that we have to move the patient to the tertiary sector. So that surgery will be the outlining method further. So SF36 is an quality of assessment scale which contains certain questionnaire to rule out certain to rule out the not to rule out, to get the quality of the quality of life of the patient, so that we can work on the other parameters to get them for better well-being. And patient specific functional scale is to analyze the activity goal, which can be again interpreted with along your neck disability index, so that can be compared together to get a better outcome as well. And fear avoidance or catastrophizing scale. So this is like we have to initially incorporate or given to the patient to assess, and we have to start therapy or the rehab plan according with it, because there are certain psychosocial factors that is coming into play. If the patient have this kind of ruminification of the pain or catastrophizing of the pain, we have to rule out that first, or we have to avoid that kind of thoughts or underconfident patient, in order that to gain confidence, and in order to give them trust on the rehab or exercises or whatever modalities we are giving in, so that we can plan the rehabilitation protocol accordingly. Otherwise we can't phase it out, because there will be more of fear and catastrophization happening over their head. It is an psychological aspect rather than other physical or physical aspect. So there are certain red flags and as well as yellow flags that we have to look into, so that we can grade triage the patient and refer the patient immediately to the higher center. So the red flags include whether there will be rapidly progressive myelopathy is happening over the patient, the bilateral upper limb symptoms are there or not. If so, there will be canal narrowing stenosis happening in a graded format, and also along with the bowel and bladder dysfunction and severe unremitting pain, the patient has been taking session for a like say for 1 week or 2 weeks, and but the pain is still there, that is getting higher on a sensation scale and higher at the night, that we have to look into why it's happening, and we have to trace the patient to the higher center. And trauma with any neurological sign, or these are the red flags that we have to look into. As well as coming to the yellow flags, these are the factors that we have to we have from our side, we are grading the patient and giving them rehabilitation approach accordingly, so that fear avoidance beliefs if there, then we have to grade it, and we have to give them confidence. And catastrophization or ruminification of the pain is there, then we have to grade with them. Or again, if the catastrophization is there in a higher format, obviously we have to seek support from a psychologist, or we can refer to them as well. And if there is any low recovery expectation or poor social support, or work dissatisfaction and previous pain episode, if it's there, they will be ruminifying, and they will be underconfident to take up the further progression. So we have to look into certain aspect as well. So these are the apart from those norms, we are looking into certain tests to rule out the radiculopathy, myelopathy, or what are the involvement of the further structures. So these are the tests which has a good specificity and sensitivity depending on the research purpose. So it includes Perling's test, upper limb tension test, and it's a cluster test to rule out radiculopathy, which includes Perlin tension test. We will be grading all the tests according to it, and will be ruling out the radiculopathy. Then Hoffman's signs, inverted radial reflex, and neck flexion test. All these have a better outcome for to rule out the radiculopathy and spine health. So coming to the interventions or manual therapy, according to the interventions that we are following. So it will be like, since we have manual therapy, exercise therapy, and electrotherapeutic approach, and certain other new modalities or new approaches has been coming to play. But this exercise therapy and manual therapy always has a higher format or upper hand in reducing their pain, as well as improving their quality of life, comparing with other parameters. Because we can't give anything as a standalone treatment, we have to combine all the approaches to get a better recovery, or to improve the quality of life of the patient. So coming on to the manual therapy, so we have certain aspect called cervical mobilization and thrust also, and that is manipulation. So we have to, as I said before, the cervical aspect will be affected. Also, according to it, the adjacent component, the thoracic aspect also we have to look into. So when we are looking into the review format, we have cervical mobilization and manipulation. So it's that mobilization we can apply it from the day one itself. We are not looking into the day 3 or day 4 to get the pain to get reduced with the modalities only, but we are looking along with the we are applying along with the modalities, we are giving mobilization as well. So this grade initially will be giving grade 1 and 2, that is only to reduce the pain and to improve the mobility. So as per the study itself, as we are giving the cervical mobilization, there is a significant reduction in pain and disability as well, and the effect maintained at 6 months. That we can maintain this like for say at least 3 months or 4 months, as we are giving this kind of mobilization, which will help to reduce the stress around the joint and to impart glide over the joint, and the structures around it. It can work well without getting much tension lower without the pain previously. So the cervical manipulation, it is one sort of high thrust manipulation, but it has a grade 2, and it only applicable to a short term rather than the cervical mobilization. Manipulation only give a period of improvement rather than mobilization. Mobilization serves the upper hand rather than the manipulation. And while giving manipulation, we have to look into certain other factors, because we have to analyze the risk according to it, analyze the we have to grade the patient, and then only we can move on to the manipulation. The other mobilization is comparing with the manipulation. Mobilization is a bit safer method and safer play to go for it. And again, thoracic manipulation, that is level 1, we can give from the first day itself, or along with the cervical manipulation, we can go for thoracic manipulation, which has given an immediate pain reduction and improved cervical range of motion. As a supporting structure, we'll also go for guarding or stiffness. We have to address the adjacent joint as well. And later is Mulligan's stack technique. Again, it is a self-natural upper facet glide. The glide we are giving, again, we can combine with the mobilization and mobilization along with the glide, so that it will improve, give a better outcome. So coming in with the therapeutic exercises, initially we have from the first or second day itself, we have to go for training the deep cervical flexor, because all those muscles will be weakened enough to take up the load, so that we have to address those muscles initially. Say for example, from the second day, we have to look into the pain parameters, and from the second day itself, we can address the muscle, because as we are targeting on the dominant ones, there are certain muscles which are taking up all the loads. Say for example, upper trapezius will be tight for these cases, so we'll be reducing the strain on the upper trapezius. But again, in order to in order to maintain the agonist and antagonist play, we have to train the weakened muscle. So we have to incorporate the deep cervical flexor training for that. So that we'll be looking on longus colli and the capitis muscles, so that there will be loss of cervical lordosis, segment instability, and increased compressive lordosis, as because there is inhibition of longus colli and capitis in the spondylosis group. So in order to maintain the curvature and to maintain the to reduce the pain, we will be training this first. Also, to rule out, we'll be checking the craniocervical flexion test in order to check the strength parameter. So the outcome measure, it has mentioned that there has been a 50% of pain reduction on giving the deep cervical flexor training initially, rather than we are moving on to the exercise session. Say for example, we are moving on to the 4th day or 5th day. So the hierarchy and dosage include the phase 1. We can include chin tucks, isometrics, and range restoration techniques. Say for example, you can impart some sort of stretching and isometrics to engage or activate the muscles, and chin tucks, which is another form of activation of your flexor group of muscles. And along with that, we'll be going on with the scapular retraction, because the scapular muscles will be weakened over there. Then we have to train that component as well, and deep cervical flexor training along with, and nerve glides. We'll be giving neural mobilization or nerve glides. These are certain movements or glides which are we giving to the nerves, so that the conduction and the neural, we can relieve the neural tension over there. If again the nerves are under tension, then again the muscles won't be contracting or acting enough to get the activity over there. So we have to include the nerve glide over there. But in this study, they have included in phase 2, that is week 3 and 4. But we can apply the neural mobilization or the nerve glide from the first week itself. And we'll be moving on further depending on the patient progression. We'll be moving on to the resistance band exercises or dumbbell exercises, and postal correction will be starting with the second week, the postal correction exercises as well as proprioception exercises. Though we'll be giving home advices and ergonomic advices initially, the complete postal complete or the correct postal correction exercises will be starting from the phase 3, so that all the muscle will be getting already engaged, the tension has been relieved, the pain has been relieved, and the mobility has come into play, so that we can actively given the postal correction endurance exercises as well. So later we'll be moving on to the functional strengthening exercises and return to activity exercises. So that depending on the demand of the patient, say for example, if the patient is into athletic population, we'll have to segregate, or we'll have to correlate those kind of exercises, and we will be giving exercises on that intensity aspect. So the modalities we are giving in is initially we can start with traction and tense, dry needling on some sort of in practice. Acupuncture is also practicing in wider aspect for this, and ultrasound therapy. And so the traction initially, like we are moving on with, say, first week, we can start with the first week, like 20 minutes to 30 minutes, we can apply traction, so that we can reduce the tension over there. So along with traction, we'll be in the first session, we'll be moving on with the flexor training, as well as the nerve glides along with it. So traction has been pronouncedly impactful for the patient to reduce the pain, stiffness, and to improve the mobility on a long run. So if the pain score is like, say, 9 on 10, we will be adjusting the traction along with the modalities to reduce the pain for the initial 3 settings. So again, coming to ultrasound therapy, though ultrasound therapy, it's, as I said, it has mentioned conditional because it purely depending on the patient's pathology or condition. So on looking into the specificity, sensitivity and specificity, this has mentioned low significant benefit over other parameters. But though the inflammation persists, we can urgently give, along with, say, in a week, we can give for thrice a time ultrasound rather than all the days. And low level laser therapy, that is very beneficial for the patient. It has given immense effectiveness in reducing the pain and disability in chronic neck pain cases. And it has been applied widely along the clinics and along the hospitals as well from the phase 1 itself. So that dosage, it can be differ according to the acute and chronic cases. But again, for optimal cases, we can give 30 joule per centimeter square. And looking into the TENS and electrotherapy, that is purely if the patient has been complained with the radiculopathy, we can go on with TENS. And if the patient is complaining of a point pain, then we'll be going with interventional therapy rather than TENS. Though both the mechanism it differ, but the effectiveness it can come into give is remarkable on. Even though it's mentioned conditional, it is helpful for the initial days for the patient to reduce the pain, as well as to improve their quality of life to a certain extent. And then dry needling and acupuncture, it's like the acupuncture has been widely used by all the clinicians nowadays to reduce the pain. And dry needling, we have been using from the first week, like on the 3rd day or the 4th session, we can implement dry needling in order to work on the tightened or the trigger point. Because obviously, as I said before, there are certain group of muscles which are getting tightened or which are taking up the load in order to function, or in order to make the in order to keep the neck or whatever parameters in a good way. Even though we have stiffness and reduced range of motion, the other parameters have to hold your neck or hold the adjacent structures to keep you move. So the muscles can go for tightness. So in order so to reduce this tightness, we can, or to point out the trigger point, we can use dry needling from the 3rd day or 4th day, and it is quite effective for the patient as well. So other recent modalities, recently we are using modalities like shockwave therapy and blood flow restriction training. It has been come into place since like maybe few years, and certain clinics and certain personnel have been using blood flow restriction training, and they have mentioned it useful for deconditioned patient and post-surgical rehabilitation. And if the patient has any kind of severe pain limiting, and during loading, like you're walking for a longer time, then we can go for blood flow restriction training. Though the shockwave therapy, again, we are giving for the patient coming in with pain. If the causative factor is a muscle, again upper trapezius trigger point or levator scapular dysfunction, and purely for the myofascial pain syndrome, we can give shockwave therapy. Apart from the usage of shockwave therapies, fasciitis, and for the ligaments and tendons, we can use the shockwave therapy over here for this aspect. And virtual reality and sensory motor training for a longer run for a chronic patient, if the proprioception and balance are affected, we can go for virtual reality and sensory motor training, which includes certain games and parameters to indulge the patient. So they will be actively participating in that, and they can have fun, and at the same time rehabilitation will be happening on the go. So this is the evidence, as it says, we have to implement all the parameters at a time in order to get a positive outcome rather than passive care only. That is, we have to implement the manual therapy, we have to go implement the exercise, and we have to educate the patient what is happening, then only we'll get a proper effective approach, rather than only giving your exercise or only going for modality. So the accountability, it shows again 58% of improvement in manual therapy, exercise, and education rather than passive care only. So in cervical myelopathy cases, there are rehab evidence and decision making. So MJOI severity classification, as I said, if it's a mild, according to the grade, if it's mild, we can go for conservative management. That is, which include your balance training, coordination. If hydrotherapy is available, it's well and good to improve the gait functioning and the activation of the muscle. There are certain parameters that we have to avoid during the conservative management, like the sustained neck flexion and extension, high flexion activities, which can impart certain force to that particular area, which will be rather making worse. And if it's moderate, in moderate, the grade is 12 to 14, and we can go for physiotherapy for say 3 to 4 months. But in between, we have to they have to consult the surgeon or the neurologist, and they have to grade the decision according to it. And if it's severe, and then they have to go for the surgical management. And after surgery, then we are going on with the week-wise plan. Surgery like laminoplasty and ACDF, we have in week 1 and 2, we'll be purely looking into the activation of the muscle, general mobility exercises, and gait re-education, wound care. And week 3 will be moving on to range of motion of the cervical and scapular stabilization, proprioception. And if hydrotherapy is available, then you can go for hydrotherapy, which is very essential. But we are not giving any kind of manipulations or mobilization right after the surgery. It's purely contraindicated. And in week 7 to 12, we'll be moving on to the purely looking into training, resistance training pattern to improve the muscular strength and functional activity. So progressive resistance training and deep flexor training will be re-education. If ergonomic pattern have to be corrected, then we will be giving advice on that, and we have to work on it. And again, driving assessment, because initially for the say 6 weeks, the person is not supposed to go for any kind of driving activities right after the surgery. So in after only getting the muscular strength and proper assessment, they are supposed to go for any kind of invasive or strenuous activity. So we have taken certain, as I said, we have to include manual therapy, exercise, and education, rather than only passive care or only exercises. That won't work, because the standalone approach doesn't have much significant reduction in pain or disability, rather than combined approach that has to be taken care of. So there are certain key recommendations and guidelines which have been put upon how to taken care of the spine health. So as per the WHO neck pain guideline 2021, that we have to go on with biopsychosocial model essential for chronic neck pain management. That is, we have to check into their psychological aspect, psychosocial aspect, then their physical aspect. They have to club the mental and physical aspect in order to improve their disability or the pain. And self-management strategies and exercise adherence are the key outcomes, that we have to give advice on how to manage the pain, as well as what are the exercises they have to stick on to. Say, for example, the isometrics or the chin tucks, the neck mobility exercises. Then we can grade them into the nerve glides or neural mobility exercises, then into band exercise, that is a resistance kind of exercise with the resistance band in all the area for the cervical, for the shoulder, and for the thoracic mobility as well. And avoid we have to avoid prolonged passive care without active rehabilitation component. The conventional physiotherapy method was earlier days was to go with passive care for a longer term, and once the pain has get down, then only they were moving to the active rehabilitation component. But nowadays, we are pushing the patient to the active rehabilitation component as early as possible to improve their quality of life and to reduce hospital stay or reduce the clinical stay or whatever it matters for them. And Airspine North America, they have settled like surgical decompression for moderate to severe myelopathy. They have recommended decompression surgery for moderate to severe myelopathy, and post-operatively they have to go for PT management mandatorily. That we have, I've mentioned the previous slide how we have to go for phase-wise management. So initially we'll be only going with the upper limb mobility. We are strictly mobilizing the cervical area, upper limb mobility test, mobility exercises, breathing exercises, then the other ergonomic adjustment. Then phase 2 will be going on with cervical range of motion, the do's and don'ts, and the phase 3 will be going on with the strengthening aspect. So clinical practice guideline by in 2018 study, they have gone for multimodal care, which is very effective in acute and chronic cases. And they have mentioned manipulation over mobilization. Mobilization over manipulation as first line, because manipulation include a high thrust velocity which can impart other risk factor to the patient. We have to get to know we get to grade the patient's pathology, then only we can move to the manipulation. And manipulation is only give very limited significant reduction in pain rather than on a long run. Again, moving on with the active exercise rather than passive modalities for disability reduction. The modalities standalone only help to reduce their pain or symptomatic, whatever they're feeling. It can be pain, or it can be burning sensation, or it can be pins and pricking needles. But we have to purely look into active exercises, range of motion exercises, strengthening exercises in order to improve their disability index. So this is a case study of a 52-year-old male office worker. Has a history of right-sided neck pain relating to thumb of over a 6-month course. And on presentation, the NPRS scale was 7/10. And Sperling test and upper limb tension test was positive, and range of motion was limited, and also presented with C6 paresthesia. There was no signs of myelopathy as well. So on assessment findings, there will be MRI findings. C5-C6 discernation was present, and on classification, Wiener classification of radiculopathy, that was 90% positive, and probability of C6 radiculopathy was reported. And the FABQ scale, that is fear scale, that was 24. Elevated occupational fear was there, so we have to look into psychological aspect for that. And start neck tool, that is an disability index that was given high risk, and also as well as grip strength was reduced on the assessment findings. So which impart a treatment plan of 12 weeks. So this include initially starting with cervical traction, neural mobilization, that is nerve flight, and pain education, as well as on pain education we can impart the modality TENS or the IFT was whatever imparts for the patient, we can give the TENS or IFT modality and dry needling according to it. And we'll be going on with the flexor training, thoracic manipulation and thoracic mobility exercises, scapular setting exercises, as well as then we'll be moving on to the resistance training, that is urgent training, resistance training, and return to work stimulation, that is ergonomic correction and ergonomic advice will be giving. And from the later onwards, independent program can be advised to the patient. We can review the patient and review the patient according to their functional activities and ergonomic aspect. So there are, as you can see, the outcomes. There is an n number of changes upon giving this treatment plan on a 12-week run. So these are the clinical messages that we have to go for multimodal care rather than standalone approach. Like we can only go for modality that doesn't work. We have to go for manual therapy, exercise education, as well as our advanced therapeutic approaches along with it. So triage is critical. We have to initially screen for the patient for any kind of red flags or yellow flags that has to be taken care of, and we have to go for training, deep cervical flexor training. That should be a cornerstone for both radiculopathy and axial neck pain in order to prevent further progression and activation of the muscles and improve the range of motion, as well as to maintain the curvature of the spine. So again, thoracic manipulation, that we have to go for mobilization rather than manipulation, and outcome measures and treatment decision has to be taken care of. We can use certain ND, NPRS or PSFS scale to grade the patient severity, and biopsychosocial screening predicts chronification and should modify treatment dosing. We have to, apart from the physical or the muscular level of screening, we have to go for biopsychosocial screening in order to modify or give a rather fruitful approach. So these are the key references. So that's it from my side. Hope the session was fruitful for you guys.
Thank you, Dr. Sreelakshmi. It was a very wonderful session. Anyway, thank you for a wonderful.
Thank you. Thank you.
Great.
Thank you. Yes.
Thank you, ma'am.